And next 20-25 minutes I shall be talking about more as a case-based this one. Now let's start with the famous quote which has been given by Woodrow Wilson. He said that the cure for bad politics is the same as the cure for tuberculosis. It is living in the open. And I think that says a lot. Similarly, William Osler said, the best preparation for tomorrow is to do today's work superbly well. I think it doesn't apply much better when you start looking actually at tuberculosis. When you look at the total burden of it, and you see it here in the reports which have been published by the Global TB Report, 1/4 of the cases and 1/4 of the mortality which is happening throughout the world in tuberculosis in this country. And one of the major reasons is it's not that we have not made development. From 400 per 1 million, we have come down to 160, 170. But it is the population and the way, because TB is nothing simply a disease, but we must remember it's an environment in which we are. Unless until we don't hit at it, probably we may not be able to achieve 2025 TB-free country. But equally important challenge has been in the diagnostics. And of late, we are finding large number of improvement in molecular diagnostics. And somebody asked me, what is it? And one of my colleagues, when I was giving a talk on tuberculosis at Hisar, he said, ki sahab, ab to ye puri pakki sarkari ho gayi. And I think that's what is important. But at the same time, everybody, all of us have an extremely important role to know, because as the new technology is coming up, our challenges are also going up day to day. Now these are the statistics. What we are finding today is that drug-resistant tuberculosis in 1 to 3%. But where is the retreatment is coming up, it is 12 to 17% of the patients who are having a retreatment. Apart from it, what we are finding is a primary INH resistant. I hope sir will agree with me, and Dr. Prem Prakash is there, who's our zonal TB in charge of the state STF, is that probably now 14% incidence of primary INH resistant today we are seeing in our country. And prevalence of rifampicin resistance is nearly 9.9 lakh patients globally. This is what we are looking at, nearly 1 million people who are having it. We are having a drug-resistant tuberculosis center, 1 per 10 million. Looking at it, the incident and total CBNet machines which are in this country, and 628, and the government is actually now going and expanding, giving it to all medical colleges and district TB hospitals. Why GeneXpert is used? Answer is this is nothing else, but we have been talking since late 90s about nucleic acid amplification test. What is the advantage of this particular test is that it detects DNA of Mycobacterium tuberculosis, that is one, and secondly simultaneously sends us to the resistant to rifampicin, which is nothing else but a mutation of RPO-B gene. So in one set you get advantages of two, A, diagnosis, and second, you also know whether you are dealing with the drug-resistant tuberculosis or not, because rifampicin is supposed to be a surrogate for multi-drug resistant with certain caveats. And along with it, obviously, the result, look at it, in less than 2 hours. It's a different issue because of the logistical thing. I give a sample today in my institute, I get result after 4 days. But when we make a request, we do get it, because they said there is one machine, there's a huge load. So again, there is a choke point which comes up because of the numbers which are there. But nevertheless, this is one thing, within 2 hours you can have a diagnosis and you know the drug sensitivity. Now the primers which are basically are in this case are, they amplify a portion of RPO-B gene which are picked up, and the nucleic acid amplification technique has made a huge difference as far as the diagnosis is concerned. And this is all automated. It is there. You correct a sample, and during this, before putting it the sample, you tend to homogenize it, separate it up, and there is a process in which they say we tend to separate it intra and extracellular DNA. That is what the claim, and through the multiple processes, ultimately you get out a printout of a report, and there is a cyclic amplification which you call as a cyclic time as you have PCR reactions, polymerase chain reaction. So that's what we see it, and under 2 hours we know whether the person is having the sample is showing us a gene of tuberculosis or not. Now let's look at a case which have been come to us during last couple of months. It's a 37-year-old male, non-smoker, non-alcoholic, bank employee, had no previous comorbidities, presented with low-grade fever, cough with expectoration. He was found to be having a sputum positive in 2013. He received ATT and was declared cured. Again in 2016, he was found to have a sputum GeneXpert, was detected low. He was symptomatic, having a progressive breathlessness. Culture was negative, and he was not given ATT. Now this was the first X-ray in 2013, and you look at it how it has been devastated. The lung has been destroyed in 2016. Now today he's admitted with us. At the present, he is presently admitted with us in the ward, and you look at the X-rays, what is happening to him. And when you do a CT scan, this was the 2013 CT scan. You have shadows here. They have again another shadow here. There, what you are finding is some amount of tree and bud appearances also. That was in 2013. But in the present CT thorax, you look at completely destroyed lung, which is there, and the person is crippled and has been treated sometime as a fungus, sometimes a chronic pulmonary aspergillosis, and other time as an ILD. So this is a young man within 4 years has virtually become a cripple, and patient had a positive GeneXpert in 2016. No treatment was given because the reason was that culture was negative. So the interpretation comes up when it was positive, why it was not given, because that's a common question which is coming up, and this patient has a treatment for tuberculosis in the past. There's another patient which is there, a 30-year-old male. He was put on Cat1 ATT in 2014 for right-sided hydropneumothorax. We discharged him only 1 week back. 4 months after stopping ATT, again had a sputum positive TB and put on Cat2 ATT. 2000 again he had a right-sided diffusion, and he was again put on anti-tubercle drug when they said that GeneXpert is positive. But when what we looked out at again was sputum positive, lymphocytic exudative. Again he presented with a fever, same thing, sputum expert was found to be positive for mycobacterium tuberculosis and sensitive to rifampicin, and the culture has been negative for mycobacterium tuberculosis. Again has been put outside on ATT, fourth time coming to us on the report of GeneXpert. This was the present chest X-ray which we are seeing in this case. This is the present CT thorax. You can see a hydropneumothorax fibrotic lesions which are coming up in this case. This is the third case which has come to us and is hospitalized right now with us. It is a 60-year-old smoker, previous history of CAD, post-PTCA, carcinoma prostate, with a past history of sputum positive TB, which he received in 2009, and has presented with a low-grade fever, cough with expectoration of 15 days. Prior to that, he has been on and off the hospital taking antibiotics. Now, this is the first X-ray in 2009. He had a lesion on the left upper and right upper lobes. Now, what you are seeing today, this is the dominant in the left upper lobe. That was the previous CT thorax. You have a lot of tree and bud appearance, fibrotic changes, and some amount of air in the cavity, water in the cavity, or what you kind of fluid in the cavity. Now this is the present CXR. You see bilateral lesions more so now coming on the right page. Now when you look at it, this patient we have given an antibiotics. GeneXpert, I will show it, its report which is there, is indeterminate, which is coming up, which is showing that CB-NAT positive, indeterminate. That means we are not able to do it twice, we have got it, and hence we are not going up for an LPA. But in the meanwhile, what we have done, we have given this gentleman antibiotics, and with an antibiotics, his fever has responded, and that is the piperacillin, tazobactam, and clindamycin. So he has responded to it, and we are wondering, and we are now waiting for culture reports. Now, when you look at the guidance document of CB-NAT use under RNTCP, now what they say today is that every patient who is coming to you, all samples you need to send it for CB-NAT. That is what the first time which is doing for the primary diagnosis. This is now the guideline thing requirements. This is also now the WHO is also saying. But the problem comes up if you have got a rifampicin indeterminate, or if somebody has treated the patients in the past. For that, they say, okay, that is the place where you need to look at the drug resistant, and they have given us another algorithm, and where they say you do a CB-NAT, a presumptive tuberculosis, or all diagnosed TB patients. You look at it whether it's a rifampicin resistant or rifampicin sensitive. When you have a rifampicin resistant, you do a first line LPA, or if it is a resistant, when you are resistant, you do a second line LPA, and when it is a sensitive, you do a first line LPA, because the drugs which you are using is different, and LPA is nothing else but is a line probe assay. And in these cases, we look for fluoroquinolone and second line injectables. That is, excluding streptomycin, we look for the kanamycin, we look for Caprio, or we look for your amikacin. Whereas if you have first line LPA shows H resistance, you give H sensitive. Now this itself you look at when you're talking about drug resistant algorithm. The problem with the CB-NAT, you can very well see it here, is what we are facing is you cannot detect H resistance. So, and we are presuming that if somebody has got a rifampicin resistant, has got MDR. So that is the first case which I am painting up, because of which we are finding a lot of difficulty and challenges when persons are coming up today with the GeneXpert positivity report, and more so when they are coming to the referral centers, and there it gets more compounded. GeneXpert, when you look at for the pulmonary samples, our research, the Kirti is there. I think the thesis is going on. We are looking sputum negative, CBNet along with the Department of Respiratory Medicine. And what we are finding is that all culture positive, if you see it in this particular report by Dr. Sharma, all culture positive, you are 95%. So the smear negative culture, if you see, the sensitivity is only 77%. And smear positive, it is practically nearly 100%. So it is very important from this perspective. And obviously specificity in both cases is important. But what happens if somebody has been treated in the past? The sensitivity says the specificity gets down to 75%. Practically, I will be talking about it in the South African study which has got recently published in CID, that clinical infectious diseases, 1 in 7 cases coming out to be false positive. Therefore, it is very important for us from the public perspective, where a high load of tuberculosis is, how are we going to interpret CBNet in those conditions? These are diagnostic in different respiratory sputum. That is what is a reputation of that. But what is very important is that what we are doing is an expectorated sputum 96%, endotracheal aspirates 87%, and BAL is nearly 90%. And it's a good tool as far as detecting them in first time in smear negative. What is important is that it tells us much better about rifampicin sensitivity than anything else. That's definitely is a good point, but now it is creating a problem, though maybe in a small number of patients, but at the same time, from the public health perspective, that becomes extremely important. As I have told you, now what we are seeing is a better differentiate silent mutation, which it picks up from resistance confronting mutations in this case. So what are the challenges I have said? It cannot differentiate between true positive and false positive cases. That's the important issue. That means, and we also know that rifampicin positivity or a sputum positive AFB have been a phenomena with rifampicin in the past also, where cultures are negative. The gold standard, we always look at cultures, which is now a midget bacterial liquid cultures, but nevertheless, still, we need to differentiate it because we are simply taking as a gospel of truth. Like every sputum AFB, we miss nocardias and we simply treat them as ATT on tuberculosis. As I said, it cannot detect isoniazid and other anti-tubercular drug resistance. It only tells you about rifampicin and has got relatively low sensitivity in extrapulmonary tuberculosis. That again is an issue, because what we are looking is a samples who are sputum may be positive or cultures positive. But when you put them onto extrapulmonary, like in a pleural tuberculosis or at other places, it may not be positive. And one has seen, Professor Jindal is also there, where people talked about nucleic acid amplification test positive and on pleural effusion, where ultimately turned out to be malignancies. Therefore, it is very important when you look at it, the site from where you are taking, what are the sensitivity specificities, and whether the person has been treated in it, we need to take in account for interpreting CBNet in clinical conditions. This is one slide I thought it will be worthwhile putting LPA versus CBNet. Unfortunately, we don't have an LPA in the whole of state of Haryana. It is done in the government only at Karnal. I think it's a need of the hour that we need to have it in our own center, and it tells you about INH and rifampicin, and what is important for it, we need smear positive only. Here you can do it whether positive or negative. Turnaround time is 3 days, roughly 72 hours, where it is 2 hours, and that is important for us. Cross-contamination operator dependency is important. This is where it has an advantage. That is why it has been put into field, because of the way it can be used with the minimal interventions. But at the same time, today we are seeing the problems as I explained to you. Why it is happening? Because it is happening on non-intact, non-viable cells. Though they claim that they are able to take it away, the extracellular DNA, but the data which is coming up, probably it is much larger claim the companies are making than what you will like to expect. Now what they said is, okay, let's do something else. How the things are getting enhanced and how it is being picked up. And that is where they put up the term of a cycle threshold. And what they are finding is that if you have to amplify it in a larger cycle, it is probability is that it is going to be false positive. If you get in 4, 5, 10 cycles, it is likely to be sputum positive or active tuberculosis. But if you find that the cycle thresholds which are there, which is much more than 26 or 30, then the sensitivity and the chances of having false positivity actually increase by 5 to 6 folds. Therefore, this is the data which is coming up, and they say we should or should not we actually put cycle threshold on CBNet. The more you things add up, the more they become complicated, and the more they become far more difficult and challenging to putting into the field conditions. I think that is something we need to take in account. Now, this is the paper which I was quoting, which has been published in Clinical Infectious Disease from South Africa. can we distinguish true from false positive results? It has shown a very interesting thing. I think I will go to it. And what we are finding is, yes, years since treatment completion of TB influenza is GeneXpert interpretations. So if somebody has come to you with the symptoms little early, then you do a GeneXpert positivity probably will be much more than somebody is coming later on. And another thing which has shown is that interpret it with the X-rays in addition to clinical picture. If your X-ray is suggestive of an active disease, these are all probabilities. Your positive predictive value in AUS is, though not very much, but at the same time it is around about 70% or so, but your probability of being right tends to be better than simply by interpreting CBNet. That means you need to do two things. One, you get a cycle threshold on the report, and second, from the clinical perspective is, if your radiology, if somebody is having a fever or as a clinical symptomatology, and then you interpret it, then probably likelihood probability is going to be better. But again, the gold standard, though it is imperfect, continues to be the culture. That is what is important. It's a bacterial disease, and we must not forget the principles of bacterial disorders, because only live organs are going to grow, not the dead organs. DNA will be there. That, I think, is a fundamental thing all my students and residents who are there, they must remember. This is again a diagnostic aggressive GeneXpert suspected retreatment, and you can't read it, but again it is showing that probably sensitivity specificity again depends upon it at what time you are doing after the treatment which has been given in the past. If it is giving a 6 months to 8 months, probability of picking a false positive are much higher. Then they said, let's come up with something extra which is there which can take over, and they're talking today of expert MTB Ultra. There is another problem which we are finding is that you may have a rifampicin sensitivity here on the GeneXpert or CBNet as we call it, but when you do it culture, phenotypically it is coming out to be sensitive. What is the reason? Resistance here, sometimes sensitivity you are picking up, there is a discordance in simple words. And what we are finding today is that it is not able to pick up, and patients when are not responding, please look for the cultures, because there are certain mutations which will not be picked up by the CBNet and which will be showing sensitive, patient not responding, cultures will be showing multi-drug resistance in those cases. So important is, if patient not responding, go for cultures. And expert MTB has tried to take care of that by putting and inserting additional few genes which can be detected, which are responsible for causing rifampicin resistance. This is the principle of detection. You look at it, I won't go into it, I will go straight away. Whether this will be able to solve the problem false positive, probably answer is unlikely, because it will not be able to differentiate from the dead bacillus. So they are trying to do it, they are putting more insertions. It may help you picking up more rifampicin resistant cases which might be missing it up. But in terms of picking up false positive may not be true. And WHO is now saying in its document of 2018 that probably where it is high dependency things, where rifampicin resistance is high, you replace with expert ultra rather than with a simple CBNet machine. The cost will be 1.5 crore for the machine itself. I think what we are talking, we are going into circles and circles, but what is important is still we can't cure the problem of true or false positive. Now look at another case which we had it, which will explain it, and then I will finish it off. 18-year-old male with past history of twice ATT intake, high-grade fever 2 months along with cough for 2 months. Family history of TB, both father and sister suffering from TB. Now this is an X-ray of this boy who has a large lymph nodes, and you can see a huge infiltration in the right upper lobe and the right middle and lower other lobes. We did fiber optic bronchoscopy, broncholith was removed, we got a GeneXpert and we got a culture which was positive, and it was sensitive, pan-sensitive, received ATT 2 times in the past. It is coming up to us. We are wondering, we are baffled what is happening. After 5 months of ATT, which is all sensitive, you can see the development of new abscesses. We referred this case to NITRD because we are wondering what has happened in this case, and what you will realize is a phenomena which is coming up with this country is, which I just found out information, rifampicin absorption is becoming a huge problem, and they did a PKPD, and what they are finding in it, there is absolutely no value for rifampicin in spite of giving it at this point of time. So if somebody is not responding, we need to look at it, whether as Inder said it in it, whether they are having therapeutic levels or not. It puts another question, should or should not we do a therapeutic monitoring of ATT in these cases. I know this is something which a question I'm putting is it's a very challenging and a controversial question. Her sister again coming to us, she put on CAT2 ATT. He's now, before coming at the reports, NITRD has put this gentleman, this boy on CAT4. He's doing better now. He was put on CAT2 ATT. And what you are finding again, she had a lymph nodes which are large, and we started looking up, she treated, cured, again coming up. And we did again, she had a GeneXpert which was positive, found to be tuberculosis positive. We were wondering what is happening. We got the father, found out he was sputum positive, and he's refused to take treatment. Ultimately, we have been forced now. I have written it to the civil surgeon that he may be put into out of that place and put into some isolation. Because what we are finding repeatedly, when 4 times son, this is the 3rd time the daughter is taking the ATT. Now let's look at it, the mutation. That was the part which we are looking at it. Sometimes GeneXpert may not be bad, which we are looking, but we need to see the clinical profile. That is my bottom line for it. And you can do the mutations which are detected with the new ones which are there. Sorry. GeneXpert, what we are seeing is in a single RPO core gene, and GeneXpert Ultra, I've already told you multiple. So multiple targets it can pick up. So multiple drug resistant mutations which takes place in RPOB can be picked up better, but there is no additional advantage beyond that. This is again a paper which has come up, which is showing the challenges of the mutations which are coming new and new every day. So our interpretation, this is the last slide. Our interpretation is advanced fibrotic lung disease with past history of anti-tuberculosis drug treatment. Previously positive, now negative. We are trying to do it. Probably it was false positive. Initially, this second case was also positive, but now repeatedly cultures are coming negative. Absolutely hatta katta admi, and therefore we have not given everything. We stopped ATT because we found out cultures. We have sent it, but the preliminary reports which are there all negative. Third case. This case again, which is an indeterminate CB-NAT, we have sent it for an LPA, but patient has responded nicely with antibiotics. So it looks that probably again it's a false positive case. And last, we found out a family history was important, and it was the father which was the source, which has been responsible for repeatedly reinfecting his children. And that's what I said, it's a social disease. It's not simply alone a bacteriological disease. So when we are solving the problem, dig at the roots instead of just hacking at the leaves. I think that is very important. We learned in the PGI that issue is tissue. Similarly, we need to go to the bottom of a problem. And then I think the CPC, that Uma is smiling, but end of the day, I think that is the important thing, because we have to go for the root cause analysis, and like a detective as a physician, need to know what is the problem. Because we stop short of going into the social environment, I think, which is very, very important for us. And this is the carrier message, my friends, is patient with a history of tuberculosis, more recent previous tuberculosis, and a CX are incompatible with active TB are at higher risk of expert false positivity. It means your CXR is normal, patient is not having clinical symptoms, and there is a less distance from the past history of treatment. Chances of false positivity are high. You need to discriminate dead bacillus from the live bacillus. Is only one bad thing you can do, that is cultures. Short of that, not possible. And diagnosis or retreatment case rests on comprehensiveness of clinicians' available medical records and interpretation of patient history to attain meaningful conclusions. It means the clinical medicine as relevant as these diagnostics are. So please do not lose your clinical skills. That is the key. What you need to do is document it clearly why you have taken a decision. What we do poorly is we do not document why we have taken a decision. It facilitates the treatment, and it also helps the physician. And in the end, the value of experience is not in seeing much, but in seeing it wisely. Probably the age has taught me, and I am certain my teachers are there. That's what they have taught. And it is primarily for the youngsters, because all the time they go with, so this is the report. Look at the patient, not at the number. Treat the patient, not the disease alone. I think that's the bottom line, and this is an acknowledgement. This is my faculty and residents of pulmonary critical care and staff. Thank you very much for patient hearing.
Thank you, sir, for a wonderful elaboration on a topic which probably is always an issue of debate. And now, as we are the fallacies which are coming up with this beautiful test, and we are now actually really able to appreciate the beauty of the test in its true sense. Elaborating false positives GeneXperts at various scenarios, yes, these patients do come to us every other day, and especially at your center, which is a referral center, even we refer such patients wherein we are dealing with practical problems in the form of one report showing GeneXpert as positive, second report showing cultures as negative, third report showing GeneXpert as negative. So what to believe, what not to believe? Very true. The clinical sense is actually very important for the clinician to make the final diagnosis how to treat these patients.
We have 5 minutes to discuss quickly.
So we can probably entertain a lot of questions on this topic, and
Yeah, Dr. Chugh and said Dr. Uma is also saying, and I will request Dr. Jindal also to make some comment on it.
About 2.8 million new cases every year.
Sir.
The government of India has worked in collaboration with the Imperial College and published in December 2016 Lancet, because a lot of cases from the private sector are not being counted. They don't report. They have looked at the consumption of ATT in the country, and by a factor of 2 to 3, we have more cases. We don't have 2.7, but we probably have 7 million new cases every year.
Very true, sir.
The second very important point is we have got 300 million cows and buffaloes in our country. And it has been seen, published by our veterinarians, 7% of buffaloes
Have
and
tuberculosis.
8% of cows are infected with active tuberculosis. And more than 50% of our milk that we consume is not previously sterilized. So the magnitude of the problem which comes to us from the bovine tubercular bacillus is huge. But we must realize that inherently the bovine tubercular bacillus is resistant to pyrazinamide. So when you are treating with 4 drugs, you are actually treating with 3 drugs, not with 4 drugs. And the US has followed their hundreds of cases of bovine tuberculosis. They are now recommending, should we treat them for 9 months instead of 6 months? There's a huge literature on this issue also. I think the medical doctors in India have not worked on the prevalence of bovine tuberculosis in human beings, except one paper, which has come from Safdarjung Hospital, that 35% of the tubercular bacilli in cases of TBM were bovine tubercular bacilli. How do we treat them when they are pyrazinamide resistant? The last one, you have very ably talked about this. We must combine our GeneXpert with DST, especially in cases where you have a confusion. You depend upon your clinical work, but the microbiology department must do DST on solid media in all these cases.
Sir, you made all 3 very relevant points. Last one is the easiest one actually. If you see the original papers which have come up, they said GeneXpert should always be interpreted with DST. That is the first, these are papers which have come up. Somewhere we forgot that part, because we forgot that the TB is a bacterial disease. We forgot the principles, but that was one thing which I look at it. Second component is bovine. Probably we have gone into that feeling that because of pasteurization of milk, that problem may have gone. But it is possible that what you are saying is true, and we need to look at the epidemiological thing. But unfortunately, GeneXpert may not be able to pick up the bovine one because of the insertion sequences which we are dealing with it. I think what Professor Jindal has to say about it, sir.
Quite right. The CDC recommends that all cases which go for GeneXpert must go on DST also.
Yeah, that is true.
I'm not recommending
It's the
that.
cost. It's the cost which is there. We are trying so hard to get a DST at Rohtak. What to talk about at any other place? Sir is sitting there. It is such a challenge, the money which is coming up. But fortunately, I think Global Fund is giving. They have done an inspection. I expect Dr. Prem Prakash, I think in next 6 months to 1 year, to have a DST with us. Dr. Jindal sir, and I think.
No, I think most of the things have been well said, and I agree with all of these. But only 2 points you see. One is GeneXpert should not be considered as the gold standard for diagnosis. The gold standard is still the demonstration of live mycobacterium. It's a good test for screening. So what we generally do, and this is the recommendation of the program as well, is that for consideration of a patient for first-line therapy, positive gene test should be considered as the starting point. You see, even if the sputum smear is negative for acid-fast bacilli, if the GeneXpert is positive, we can always start the standard therapy. You see, however, to interpret rifampicin resistance from GeneXpert alone and start second line or fourth line anti-tubercular therapy is not recommended at all. It is only screening, you see. If GeneXpert shows rifampicin resistance, then there is a case for drug sensitivity testing, you see, before you start the second line treatment. And in any case, if a case comes for the first time without any exposure previously to anti-tubercular treatment, and if GeneXpert shows rifampicin resistance, there is no case at all for starting second line therapy in the first instance, you see. In the first instance, if the patient has never been exposed to anti-tubercular therapy, he should be started on first line therapy till the results of culture become available. I think that is what is a practical point as of today. What is going to happen with the next kind of research, I cannot say, you see.
So, Professor Shivat, sir.
I think I just wanted to make 2 points. One, I fully agree with Dr. Chugh that the incidence reported is much, much less than what it is actually. Actually, it is only the tip of the iceberg, and the reporting is much less, especially from the private sector, the method we are using. I was just wondering, Dr. Jindal, that with the problems coming up with the resistance and hepatotoxicity with rifampicin, why don't we think of taking it off from the first line drugs?
Resistance to rifampicin is no more than the resistance to other anti-tubercular drugs, you see. Same is case for hepatotoxic effect. In fact, pyrazinamide is much more hepatotoxic than rifampicin, you see. So I don't think as of today we can do away with rifampicin, you see, unless we get very safe, ideal drug. For the time being, both INH and rifampicin are the ideal drugs, you see, in fact, as far as tuberculosis is concerned.
That's a short comment because we will then run out of time. We had 6 minutes, so we have covered that. So
this is the most potent drug which goes into the cells and kills the dormant intracellular microorganisms. You cannot take it away.
Yeah,
we have to live with it. On the contrary, it is recommended, it is very safe to use as high a dose as 2 to 3 times of the current dose.
Sir, in fact, today we are talking of high dose of rifampicin. I think that's entirely a different topic. And thank you so much.